Okay, welcome everybody. I see that we're starting to get to be a quorum under participants. Okay, so if any of those caught your eye and you said, oh gosh, I didn't scan those rapidly enough, you can find them all on the Office of Lifelong Learning website. Those were just a bit of a teaser, and welcome everybody today to the Navigating Household Food Insecurity in Primary Care, a Nutrition Guideline, hosted by the Office of Lifelong Learning and Physician Learning Program at the University of Alberta. So my name is Denise Campbell-Sher. I'm the Associate Dean of the Office. The office is committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to addressing the challenges related to food insecurity. So we want to acknowledge today that we're on the traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. And I'm going to give a little bit of logistics, although at this point in the pandemic, I'm sure you're all very familiar with Zoom. But if you have questions about technical issues or L3 programs and services, please use the chat feature. And if you have a question for the speakers, please use the Q&A feature of the webinar. Please upvote questions you'd like to have answered, review what's been asked. We can't necessarily guarantee that the panelists will be able to respond to all of your questions. A recording of the webinar will be sent to everyone who registered for today, together with a PEARLS document and resources. Main Pro Plus participants may earn certified credits by completing a linking learning exercise. MOC and Main Pro Plus credits can be earned by completing a personal development activity using the My L3 Plan tool. For more information, if you scan this QR code, it will take you how you can earn some certified credits. This activity has not been formally reviewed by the CFPC or Royal College, but it is also eligible for non-certified credits. So we're delighted today to have an amazing panel with us to talk about this important topic. I'd like to introduce Dr. Richard Lewanczuk, Shawna McGhan, and Kally Chung. And I'll start with introducing Richard. So Richard was the Senior Medical Director for Primary Healthcare for Alberta Health Services from its inception until 10 years ago, until January 2019. Then he evolved to become the Senior Medical Director for Health System Integration, which is AHS's long-term vision for integration within the healthcare system, as well as across sectors which determine health, such as the volunteer sector, other government ministries, municipalities, and business, all with the goal of keeping people as healthy and well and independent as they can be in their homes and communities. And prior to the formation of AHS, Dr. Lewanczuk was Medical Director for Chronic Disease Management in the previous Capital Health Authority, perhaps to be again. Dr. Lewanczuk has been involved with chronic disease management and prevention for most of his career and has contributed to many national and international bodies and initiatives which address either specific chronic diseases or health system integration. He received his MD and specialist certification in internal medicine and endocrinology from the University of Alberta, and he holds a PhD in medical sciences and medicine. Shawna McGhan is a master's prepared registered nurse who has worked in chronic disease management and primary healthcare and now health system integration within the provincial portfolio of Alberta Health Services. She's been working to support a health creating team that collaborates and learns alongside with other health teams, communities, and sectors. Using human-centered design, she's been exploring innovative approaches to enable system change around social determinants of health in partnership with primary care and community. She's been an integral part of the leadership team on projects such as reducing the impact of financial strain, and patients collaborating with teams. So welcome to Shawna. And Kally Chung is a public health nutritional provincial lead with the Nutrition Services Provincial Strategy Team at Alberta Health Services. And one of her focus areas is to build understanding of household food insecurity in the Alberta context and partner with health teams, care providers, community groups, and researchers on actions to support those experiencing household food insecurity. She is a registered dietitian, a certified diabetes educator, and has a master's of public health from the University of Alberta. So prior to her current role, she practiced clinically in areas such as pediatric nutrition, diabetes, and eating disorders in both rural and urban Alberta. And she also supported research in Indigenous communities on nutrition and food environment. So thanks everyone for your time. So excited for the strong registration for today. And welcome to our part 1 L3 webinar on this important topic. And you are on mute, Kally.
That way the sound check. So I just want to thank you for the introductions and thank you everyone for joining in today on this important topic. Every day we hear stories about Albertans, Canadians struggling to cope with the rising cost of living. What can we do as health professionals when we know our patients are experiencing household food insecurity? Today, we want to share some ideas, resources, and tools to help support your practice. I will start with providing an overview of food insecurity. Dr. Lewanczuk will talk about its impact on health. And Shawna and I will share stories and tools that might support your patients. Household food insecurity is a symptom of financial strain. Essentially, when the money that someone has is not enough to cover all their expenses, it's often the food budget that gets cut first. And this is because the money for rent and transportation are often fixed costs over the month, and there's little to no wiggle room in those expenses. So when we look at household food insecurity, we know it's more than food. It's a marker of a larger struggle of not being able to afford basic needs and withstand sudden income shocks, like a loss of job or rising food prices. So how big is the problem? And I'll invite you to interact with our poll. We have 2 poll questions. Andrea, if you can pull them up, please. So what does this experience look like? It sees that most people are thinking it's over 30%. Some second choice is about 20%. Andrea, can we have the second question? Yeah, the purpose of these questions is just to have some common understanding of what household food insecurity might be. All right. So according to the 2022 Canadian Income Survey, 1 in 5 Albertans experience household food insecurity. And we know the prevalence among those with chronic disease is higher. Often, when people think about food insecurity, you have the image of bare cupboards that comes to mind. But in reality, there is a range of experience, and it includes worrying about having enough money to buy food and compromises to what kind of food they buy. Any experience of household food insecurity, including feeling worried, has tremendous impact on psychological, social, and physical health, which Dr. Lewanczuk will elaborate on a little bit further. So who experiences household food insecurity? Food insecurity is a sign of inequities. Groups that face social and economic disadvantage are at higher risk of food insecurity and poverty. While income is the biggest predictor of household food insecurity, it's important to note that unemployment is actually not a key driver of household food insecurity. In fact, 68% of households that experience household food insecurity in Alberta rely on wages and salary as a main source of income. Having a job doesn't mean that you have enough money to meet your basic needs like food and shelter. And with the inflationary pressures that we're facing, the problem is getting worse and more people are being affected. I'll pass it over to Dr. Lewanczuk to talk about the health impacts.
So how does food insecurity impact health? Okay, there we're going out. So all levels of food insecurity do have a whole host of adverse health outcomes. We know that people who are in food insecure households, as Kally already alluded to, or as the questions alluded to, will delay or reduce amounts of food, but will also, if they happen to have chronic diseases, will end up reducing the amount of prescription medication that they may use, for example, or totally avoid purchasing medication in favor of being able to buy food. Flipping it around the other way, if we look at the percentage of people who can't afford prescriptions by drug class, food insecurity being a marker, we find that anywhere from 8 to 20% of our population can't afford their medications. And that's often manifest, as we'll talk about in a moment, through detecting food insecurity. We also know that adults who live in food insecure households are at greater risk of poor mental health, regardless of the level of food insecurity. But the more food insecure people are, the greater the challenges are for mental health, as you can see here. Food insecurity also is a marker for other conditions and other risks, and people who are in a state of food insecurity, again, more likely to have poorer health and therefore to need more health care, and in this case, to be admitted to acute care for a variety of reasons. And we'll explain more about this in a moment. It works the other way as well, is that if you do happen to have chronic health conditions and are unwell, you're more likely to be at risk of household food insecurity. So I want to talk a little bit about I'm going to put on my endocrinology and physiology hat for this, a little about the consequences of food insecurity. So one of the things that we do know, if you remember Maslow's hierarchy of needs, at the very basic level, we need oxygen, we need water, and we need, you're anticipating that I'm going to use the F word, food. That's not true. We need oxygen, we need water to survive, we need a source of energy for ourselves, we need protein, we need essential fats, we need calcium, magnesium, iron, boron, selenium, we need vitamin A, a whole host of vitamin B, vitamin C. You get the idea. We need a whole host of building blocks for proper health. The one thing, though, is that every one of us, now a lot of people don't believe in natural food products, but we'd be a little bit hypocritical in that, because 100% of people in this webinar use natural food products, or natural products, health products, I should say, several times a day. It's just that we call it food. And so food is a natural health product, which provides us with all of those things that I listed, the minerals, the vitamins, sources of building blocks. And the challenge with food insecurity is that, as Kally's already said, is that we either decrease the amount of those critical building blocks, or we substitute that natural health product known as food, which doesn't contain the building blocks. So to put it in plain English, if you don't have enough money, if you only have a little bit of money, you might go to the dollar store where you can buy pasta for 99 cents, which does give you that source of energy. And because our flour is fortified with folic acid, a little bit of folate, that's about it. As we become less food insecure and become food secure, then our diets can provide us with all of those critical building blocks that our bodies need. So if we think of food as really that source of building blocks, it really helps us realize the impact of food insecurity. The other things with respect to food insecurity is that when we're short of food, it can certainly cause, again, as has been alluded to, mental strain, but it also causes the physical strain of not having either the right type of food or the right amounts of food. But the thing about the body is that your body does not differentiate between sources of stress. So whether you have physical stress, mental stress, emotional stress, it's all the same to your body. And so therefore, your body is triggered with this stress response. And this stress response has many, many adverse consequences. So what we now know is that low-level stress triggers triggers low-level inflammation, for example. And low-level inflammation is a little bit like the holy grail of disease across our society, both chronic disease and diseases that we might not even anticipate. So things such as obesity, type 2 diabetes, hypertension, cardiovascular disease, kidney disease, arthritis, cognitive impairment, and even some cancers all have their upstream genesis in stress. And so food security, ultimately the stress is induced, can lead to these conditions. The other thing is when you are food insecure, when you don't know whether you're going to have food on the table tonight or where your food's going to be coming from, then there's a decline in preventative care. So you could care less about some number on a blood test telling you what your cholesterol level is or what your glucose level is, or some number on machine telling you what your blood pressure is. You have more immediate concerns like food. And so therefore, you tend to only seek medical care when you have an acute problem, and preventative care falls by the wayside. We also know that in the absence of food security and proper nutrients, there's an interference with the control of some chronic conditions. So I think everybody's pretty aware of the need for regular food and regular high quality food in order to maintain control blood glucose in diabetes. But the same thing applies to hypertension. Quite often cheap food is high salt food, which makes the control of hypertension much more difficult. When we're short of money, often people defer to that 99-cent pasta, which is a high source of carbohydrate and refined carbohydrates. And when we have a high intake of that, that stimulates insulin production, and high insulin levels stimulate an enzyme known as acetyl-CoA carboxylase, which is the key enzyme which results in fat formation, and hence the propensity to gain weight, to gain fat, which then leads to insulin resistance, diabetes, and which, as I saw in an advertisement prior to this webinar starting, is why the ketogenic diet has a benefit. Heart failure, again, high salt diets, typical of poor quality food, contributes to poor control of heart failure. Even conditions like asthma, various GI conditions, chronic kidney disease are all dependent on a healthy diet of, again, the Goldilocks principle of not too much, not too little, but appropriate nutrients. In childhood in particular, the lack of appropriate nutrients can set children's health on a downhill course on a lifelong basis, as well as the stress of not having enough or adequate types of food can have an impact on childhood health. But we're also aware that it has an impact on learning ability for children. So if we miss those key years where children's learning is critical, again, it can have lifelong impacts. And finally, people who are busy trying to address food insecurity have less time for the healthy social connections that are so critical to our health. You may have seen that the World Health Organization this week listed loneliness and social isolation as yet another epidemic. So less chance, less time for social connectedness. So food insecurity is really just sort of like the tip of the iceberg in terms of a number of factors which can affect our health and a number of ways in which our health can be affected. So food insecurity also heralds things like housing insecurity, poor social connections, financial insecurity, as you heard. So often it can sometimes be that canary in the coal mine. So I'll hand things back over.
Thanks, Dr. Lewanczuk, and you provided really compelling examples of how the experience of household food insecurity affect our patients. And maybe what I'll do now is just share a story. It's a story from a patient who was involved with the Reducing Financial Strain Project, who was just kind of sharing her experience of what it's like to live in those insecurities. you can all hear.
When customers saw me as a 14-year-old, back badly as a 14-year-old, and have been in constant pain since that day. I got worse over the years, but I built up a tolerance and learned to live with it. Throughout my time working at the photo counter, it became harder and harder to do my work. I had to sit down a lot, hold on to the counters as I walked. I could barely carry the boxes of supplies. My customers would see me struggle and offer to help me. Many of them would come behind the counter to hand me their flash drives or offer to lift a box. They did what they could to help me because I always provided great customer service. 3 years ago, our granddaughter came to live with us, and I was experiencing a constant 6 out of 10 pain. I couldn't even sweep the floor anymore. I had to retire. The pain pills I had prescribed were expensive, but working at the drugstore, the discounts and benefits had made it manageable. All that changed overnight with the extra mouth to feed, my husband's own health conditions, and my loss of wage. We really had to tighten our belts. I started rationing my pills to make the prescription last 2 months instead of 1, and we made it. Recently, I had some severe back spasms and I decided to go to the doctor. I can see the suspicion when I told him that my pain was an 8 out of a 10 on the scale. This time I asked, can I get an MRI for my back to see what's happening? And he said, well, it's unlikely it's your back, and it doesn't seem like you're in much pain anyways because you're not filling your prescriptions regularly. That interaction didn't make me want to come back with flowers, homemade jam, or coffee. I'm not sure I'll ever go back. I know what it is like to provide good customer service by appreciating your customers, listening to how they feel, and show that you understand what they need. That's the only way they will trust you with the most important moments of their life.
That's so very impactful story from Teresa. And the main message I took away from it is that, in order to provide good care, we need to take the time to ask and hear about a patient's story and all the impacts that their life has on their health. So what can we do to support patients? This is a framework from the National Academy of Science, Engineering, and Medicine on how we can integrate social care into the delivery of healthcare. Here we provide examples of activities based on food insecurity and financial strain. This framework talks about 5 areas of action. First, and most importantly, it is grounded in awareness of the financial circumstances that the patient is facing. And once we're aware, we can adjust care plans based on the client's context and assist with connecting to services and support. With an awareness of how many patients experience financial strain, you and your team may start to look at aligning service delivery to better meet their needs. For example, extended care or virtual visits to reduce the burden of commuting or taking time off work to attend visits. You may also advocate for patients by partnering with others to reduce the burden of financial strain in the community. And the Reducing Impact of Financial Strain work has a lot of great resources that talk about that partnership. I'd like to hear a little bit about your current practice. How often do you ask your patients about financial strain? Jay, if you can load the poll. Hey, it sounds like many of you are already asking about financial strain. I'm really curious, what does your team do if a patient experiences food insecurity and financial strain? So we'll try an open-ended question here. And we'll see how this works. Andrea? So you just type in your answer. Maybe we'll use the chat function for the next question. But just judging that, I'm just seeing that many of you are already asking about financial strain. I can imagine that when you're doing practicing, your practice may align with some of the suggestions that we give in our nutrition guidelines. And I'm really hopeful that what we have, the resources and tools that we have to share today may help to either validate some of the work that you're already doing, or maybe be able to add to your toolbox for your next planned patient visit. So in AHS, we developed a suite of resources to help you talk about financial strain, develop care plans, and explore opportunities to connect to community supports. It aligns with the aware, adjust, and assist step of the framework that we shared earlier. And the goal is to provide better care by reducing stigma behind household food insecurity and financial strain, and getting the full story so we can identify appropriate supports and interventions. In the next series of slides, I'll highlight a few tips from each step of from our guidelines. The first step is asking or screening. And we can offer better support if we know whether patients are worried about having enough money for food and other basic needs. By normalizing financial strain and asking about their circumstances, healthcare professionals can build trust and provide recommendations that are realistic. Some care providers are hesitant to ask about food insecurity or financial strain because they feel like they're opening a can of worms or don't have the resources to fix the problem. Asking is not about solving problem. It's about showing empathy and care for the patient. It's about not unintentionally causing more stress by providing unrealistic care plans. Lacey and Dr. Ojenikin will share their experience of asking the question in their clinic at next week's session, has shared that they're seeing more patients coming into the clinic in a less acute state because the patients are feeling more comfortable enough to talk about their care plan as soon as it's not working or circumstances change, like something being more expensive or not having enough money. By asking, normalizing, and considering the social context in the care plan, you are making an impact. And it could seem awkward to talk about finances. It's not something commonly we talk about in our society. And many healthcare professionals may feel like they have a lack of knowledge and experience on having the conversation. Some tips we share in our guideline is start the conversation by asking for permission and normalizing. It gives patients a sense of personal power when they may feel overwhelmed or unsure. And patients always have the option not to answer a question, and we should let them know this. It's important that a patient understands why they're being asked about financial strain. For example, you can start a conversation with how much money you have to buy food affects your nutrition and health. This is an example, what you see on the screen in front of you is an example of how someone might ask the question, but it's in no way a script. Every patient is different, and let your experience guide you in having these conversations. The resource noted below, Module 2 of the Financial Strain course, goes through many communication strategies that can help you create that safe and respectful place to talk about financial strain. This is a validated question used to detect financial strain. It's developed by the Center of Effective Practices with support from the Alberta College of Family Physicians. And we received feedback that some patients may not understand the term make ends meet. So if that's the case, we do suggest explaining the question or using other ways to ask about financial strain if your patient doesn't understand. And why do we use that question? And we know other organizations may suggest using different screening questions to ask about food insecurity, like the vital signs screens. Studies on lived experience of patient tells us that their struggle is about more than food, and it's about not having enough money. And it affects their life in so many different ways. We suggest asking about financial strain because it gets us talking about the root causes. It leads to conversations about other aspects of patients' life that affects what and how they eat, including their living arrangements or access to transportation. This second step is about understanding the impact of financial strain and developing a care plan based on the patient's situation and priority. You might follow up the financial strain question by asking about how it impacts their access to food and other basic needs. More specific foods and nutrition-related information will likely come out of this conversation or this clinical assessment that you have. You might ask them how many times you eat in a day, what foods do you usually have access to. And this question may also help bring up other barriers in accessing food and other basic needs, such as living in an isolated community or physical limitations or mobility issues. And this information can help inform the type of service your patient may need to address those barriers. Our guideline contains examples of the considerations when developing care plans if food insecurity and financial strain is identified. This last step, step 3, intervening and connecting, is about linking patients to income-related programs and services where available and desired. In this section, I'll highlight a few resources you might find helpful. Before we go into this step, I think it's important to not assume that patient want or require assistance. They might be very resourceful and doing everything that they can already. So, as part of your assessment, information about employment, living situation, and benefits that the patient might receive may come up. And tax returns are required to access many funding options and benefits like disability tax credits, GST, child benefits. A 2020 study found that about 1 in 10 Canadians do not file their taxes, and non-filers are most heavily concentrated in lower income brackets. Barriers to filing taxes may include language barriers, cognitive issues, or a lack of awareness. And, as Dr. Lewanczuk had talked about earlier, when you're faced with insecurities and chronic disease, you might not be in that space to file taxes or do other administrative tasks in your life. Asking your patients whether they filed taxes and referring them to free community income tax clinics may help them access unclaimed benefits. And this is asking about if the clients, if they filed their taxes, is a follow-up question recommended by the College of Family Physicians. And yes, while this situation may not apply for everyone, when it does, impact can be huge. The next resource I want to share is after government benefits through tax filing in the previous slide, there might be additional resources available depending on the patient's situation. And we have this resource that provides a summary of funding options available to low-income families for special diets and nutrition products in Alberta. For example, if someone is receiving age and has diabetes, they might be able to receive an extra $44 a month to help manage their diet. I know it's not a lot of money, but when you're in that situation, every dollar counts and is helpful. To access this funding, they'll need a letter from a physician, dietitian, or nurse explaining the condition, the type of diet required, and the duration that the diet will be needed. To make this process a little bit easier, we have letter templates available to help you with filling out their funding requests. If you go on to hs.ca/food insecurity, you'll see a listing of all the different resources I've just mentioned. This is a search tool that indicates whether a government benefit program like income supports, age, interim federal health program for refugees, NIHB, etc., covers formulas for children with feeding difficulties. And then benefit navigation. There are a few options for benefit navigation to help maximize or identify service and programs that might help the patients. Firstly, explore whether your clinic has access to a community navigator or social worker for patients. Alberta 211 is another source of support. It offers phone or online chat options where they can coach patients on different services available to them. Your local family and community support services may know about local supports that are not listed in 211, such as programs that can address basic needs, like low-cost transportation, as an example. If you do refer to patients to benefit navigation, make sure they understand what to expect and try to facilitate a seamless transition if you can. And lastly, we can't overstate the stress and the pressure, the experience of household food insecurity and financial strain causes. You might also want to explore whether access to social and mental health supports would be helpful. Examples of social supports might be young parent support groups in the community or older adult social groups. Because household food insecurity is a sign of a larger struggle, we have suggested connecting patients to financial supports first to enable them to address their unique needs and circumstances. But some patients may benefit from a referral to a food bank in conjunction with financial support. Find out what foods the local hamper provides and the eligibility requirements. Share the information with patients to help them decide if it's something that they want to access. Food banks can bridge the gap, but they are also struggling to keep up with demand. And it's seen in the food that they are able to provide or the number of people they're able to serve. In our review, we found that 4 in 5 people experiencing household food insecurity don't necessarily access the food bank because of different barriers or challenges. Firstly, there is the perceived stigma with going to a food bank. For some food banks, there is an invasive intake process. So if you take a look at figure 2, it requires you to tell the person how much money you're taking in and all your expenses in the last 30 days, which some can perceive as being invasive. Another challenge is that the food's not matching their medical needs. So, for example, someone with celiac disease may not be able to get gluten-free food, or someone with high blood pressure may not be able, or heart disease may not be able to access low-sodium food. There are also cultural needs that may not be able to be met. And so oftentimes, the food hampers may not have what the patient needs the most for good health, such as vegetables and fruit. And there's also other barriers like transportation, hours, and operation. So food banks they're there to help, but it may not be helpful for all clients. And certainly there's barriers to accessing it. So the key message is to know the realities of what's offered and be able to connect patients if you're interested. I'll conclude my section off with this slide. I focus my discussion on collaborating with patients, and I'll pass it on to Shawna to talk about what collaboration can look like for teams and communities. Show some insight from other frontline teams.
Thank you, Kally. I had the privilege of working with a number of teams that participated in the initiative reducing the impact of financial strain. And it was primary care networks taking an analysis and testing ways to support individuals with financial strain, the patients coming in the door. But at the same time, they worked very closely with community teams that consisted of many sectors, community partners, community members who looked at a community solution to those with financial strain. And so it was this incredible partnership, and I wanted to share some of their insights along their journey of really how they could make a difference. And I want to just use their digital stories to amplify the voices and amplify their insights. And it really helps summarize a lot of the points that have already been made. And I'm gonna, maybe if you can advance the slides, Kally. I'm not seeing the slide advance here for me. So one of Joanne's, I've got a little clip here from a number of stories. One of Joanne's big aha moments was just how important it was to start from a place of empathy and to really check in with your biases and sort of what you feel is the solution. You just need to, of course, spend less or do X, Y, and Z. So just really understanding that deepened their realm. And you can see they have a graphic recording of their poverty simulation that the primary care network staff all participated in. And just how incredible when you were walking in their shoes in it over a matter of a few hours, how incredibly impactful that was in appreciating the kind of difference that you can have and the situation that they were in. Let's take a listen.
I don't think any of us expected it to be such a powerful experience. After years of having these conversations with others, I had a much deeper understanding of their daily reality. Many of us commented about how it was so exhausting to live with financial strain, and we only did it for an afternoon.
Now, the next story is from Stephanie, and she's a nurse in a primary care network, and she talked about her journey through financial strain and how invisible it was to most people around her, that they didn't appreciate all the little things that were really impacting her ability to make ends meet and to afford food and to care for her family, and just the huge impact that had on her life, but the supports being so important. So she would emphasize, let's uncover the invisible. Take a listen.
Still, every day, I meet people in my work as a primary care nurse and health educator that do not have the same supports I did. I know how small things can compound and negatively influence your health.
The next story is from Tara, and she is with the community liaison with the primary care network, and really looked at how important it was to build on the strengths of patients and the strengths of the community and collaboratively discover those solutions. Listen to her story clip.
I tried my best to optimistically navigate what seemed at times as an ever-changing system, policies, procedures, and resources. I had to put the pieces of the puzzle together backwards. I started with the person in front of me. Who were they? What are their strengths and challenges? What did they need to access the resources to move forward? Ending with, what do we currently have in our community to improve their health and support their wellness?
The next clip is from Brian. He's an executive director of a primary care network and was also part of the poverty simulation. He talks about how let's try starting this one question. Do you ever have trouble making ends meet at the end of the month? On a Thursday morning, once a week with one physician, what can happen from that? What can we learn? And just the transformation in the people's shift in how they think about financial strain, household food insecurity, and how it can shift practice. Listen to his story.
We have learned so much about financial strain, the community, and also a process we can use in other areas to continually improve the care we provide. In the end, it was so much more than just another question.
And Shelley's story, she talks about
the pandemic taught me
during the pandemic how she really supported patients by just having a conversation that was what's important to them, and ensuring we're not seen as we're going to rescue and fix you, but more become like neighbors, and what that can do along the journey of trying to help find a way through some of their struggles. Take a listen to her story.
The pandemic taught me that it is arrogant to think that we as healthcare providers can fix everything. But the beauty of working in a small town family clinic is that we truly are all neighbors, and we have a lifetime to support each other's health.
So what's exciting is these two of the PCNs shared here have been recognized for their work with Patient Experience Awards. And you'll be excited to hear from one of them, the McLeod River PCN, with Dr. Jetikin and Lacey sharing all their incredible experiences at our next webinar. But just how they were able to create space for conversation and create that opportunity for community connections in working alongside with patients. So in the next slide, just looking for a sense of what might resonate with you. How might you continue to move forward on how to support your patients? Is there perhaps an opportunity to start conversations with your team, perhaps using these stories, perhaps using the resources? Is there something you want to test or inspire others to try making a few of these changes? And challenging you to think about how can we build on the wisdom and the assets and the potential of community and our partners in the community and really co-design solutions. So you've heard over the course of the webinar a number of our resources, and I'll just quickly highlight some of those for you. So our first resource that you heard through, and I'll just have Kally flip through them, is the Household Food Insecurity website. And so the guidelines that you heard today, it outlines a number of all the tools and resources. So encourage you to check that out. The next resource is the Alberta Medical Association. So as part of the Reducing the Impact on Financial Strain, they have a change package. They have a number of tools. They have a training program, a really great resource to tap into for you and your team. And then the social workers within HS have put together a module on identifying reducing financial strain. And so Kally referred to some of those tips and resources in that program as well. And as well, the Reducing the Impact on Financial Strain website. So the digital story clips that you saw, you'll see the full stories in this, as well as toolkits and the results that they found, the actions that they took, and you'll see that on this website. So as we wrap up today, we wanted to open it up to you now and invite you to share what resonated and what do you feel would be feasible, worthwhile, something that you'd like to take away and try in your setting. And so perhaps in the chat, invite you to share your thoughts, reflections, and something that you might want to try, and invite any questions and insights you would like to share.
Pop it in the Q&A, folks. Some folks have already kicked us off, Shawna, if you want to have a look in there.
Okay. So, Kally, do you want to take on the first question? Are you aware of the Flash Food app?
Oh, yes. So I can see here that there's different types of programs that people are sharing. And, there are a lot of innovation in the last number of years for monies, for saving money, etc. I think it goes back to the importance of hearing the patient's story and their context to understand what would be best suited for them. I know that for some patients, this might, flash, like those discount apps may work very well if they have the means, such as having reliable transportation to arrive at a certain time, or like the food that's being offered, they could certainly save some money. But we do also know that the reality of some of the individuals experiencing a financial strain or household food insecurity, it's just getting to work is a challenge. taking the bus, and the idea of needing to be somewhere on time may not be suited for them. And they might be limited in terms of what kind of foods might be available through the Flash app. So absolutely, it's maybe a tool in your toolbox, but it is also just reinforcing the importance of hearing the patient's story to understand what will actually be something that's worthwhile with recommending to them.
That's super. And there's some other ones here that are a little bit regional. I wonder if people are aware about the informalberta.ca tool. Have people heard of that before? Because it's a way of finding stuff that's close to where you're at. So it's just informalberta.ca.
Yeah, and that's part of 211 that Holly highlighted. Richard, do you want to speak to that?
So we work closely with 211. 211 uses the Inform Alberta database, and so they have over 35,000 resources. So they try to keep all the resources at provincial level, but also to local level up to date. Sometimes it can be challenging to be up to date at local levels. So whatever local resources and sources you can access, that is good as well. But it's a good place to start. 211 also, if you call them, so that you can access them by email, text, or phone. If you call, they will try and make sure that they solve your problem. They will close the loop to make sure that the problem is solved. So they're more than just, here, call this number or go to this place type of resource.
Yeah, and I'm seeing some questions around or comments around community navigators and how that would be easy. And again, so the 211 is the support, and there's a number of community navigator in place, especially for healthy aging and senior populations. But there are various community navigators around the province, and a lot of the participating primary care networks and many others now are looking at those opportunities. But that certainly was a key piece with the work that was unfolding. And I see a comment around implementing the question for financial strain in our community health center, and that's excellent. The tool is available, on all the resources that we pointed to, and I'm pretty sure all the teams that were highlighted would love to share their experience and how it really snowballed. But you'll hear more from Dr. Ojedikin and what that looked like in using that question and others that unfolded. Kally, are there others that you want to jump in on?
Just take a look. Yeah, so I just see that there's different, just talking about different programs that people are sharing, different programs that's available in the community. So I see Rochelle's talking about I think a food prescription program. And then there's Joanne's working with volunteers at the local bank to explore their biases. So it's from Lorna, and you know what? I think I've heard about the Red Deer food bank. Just really doing more with the service that they provide, including linking to benefits navigation in the community. I think in the Edmonton Food Bank, they're aside from the food hamper, they're also providing training supports with resume and employment and resume benefit navigation. So it's just really great just to see these community services expanding, and also not only providing the food in the emergency situation, but also looking at how else they could help the individual in the longer term. I see a comment about the good food box, and I think it's a good example of how people the communities coming together to come up with different solutions or ideas to help each other out. I would just share that. I would just think about whether or not, in our research we had in our evidence review, we found that transportation or even just having the money is often a challenge for many patients experiencing financial strain. So that might be something that would be great to consider as part of developing those programs, making sure that it's equitable in terms of who can access it. And someone remarked about having boost or meal replacement shakes. You know what? I'm not too versed with benefit coverage, but I do think that some meal replacements are covered with a prescription. Is that right, Doctor?
That's true. I'm not sure the details, but some are. I have a patient on ACE who's covered.
Yeah.
And I see a question about social prescribing, but I see we're at time. So Denise, should we turn it back to you?
Wow. Well, the hour went so quickly, and I think there was such a lot of conversation. So I think we should just pick that right up next week or next time when we come back together. And if everyone could just take a minute and fill in the evaluation as well, that would be super helpful because we want to make sure that we always reflect on the comments and experiences of people who participate so that we can keep refining things. And just really want to thank Shawna, Kally, and Richard for their informative talk today and for all the resources. It's just a testament. I think well over 250 people registered for today. And I think this is just reflecting how much people are seeing this in their practice in the community. So timely, and really appreciate all of you and your expertise. So look forward to next event. And does the panel want to have a last word? Kally, Shawna, Richard?
Yeah, no, thank you everyone for participating. Looking forward to the second session, which will be a little bit more application to practice. We'll start out with a case study and hear directly from Lacey and Dr. Ojenikin, who's implemented in their clinic setting. And
Andrea, maybe we can just take note of the remaining questions in the Q&A and feed those back to the folks for next week to see if there's some great questions in here about things about how to integrate elements on financial strain into programs, et cetera. And so maybe the panel could think about those for next time as well. So thanks, everybody. Have a great afternoon. And thanks for all that you're doing to help support our community.
Thank you.